In the world of oncology, a routine blood test isn't just a checkup. Nope. It's really the start of a high-stakes investigation. Today, we're going to decode exactly how specialists read the hidden clues in your blood to solve some major cellular mysteries. Okay, so picture this. You get your blood test results back. It's a page, right? Just full of numbers and ranges. But for a specialist, that page is just chapter one. The real story, the one that can change everything, is often hiding between the lines. So what exactly is that story? Well, this whole investigation really relies on two key tools. First, you've got the complete blood count, or the CBC. Think of this as the initial report from the crime scene, just the raw numbers, the basic facts. Then, on the other side, you have the peripheral smear, or PS. This is our expert eyewitness. It's a manual exam that gives us the pictures, the actual visual evidence that tells us what's really going on. So every case we look at opens with the CBC. It's an automated test that gives us that first set of clues. They're crucial clues for sure, but they're also incomplete. It gives us the what, but leaves us hanging on the why. The CBC report lays out a list of clues for us. We get numbers for hemoglobin, white blood cells, platelets, even the size of your red blood cells. Sometimes the machine will even flag something it thinks is unusual. But again, these are just numbers. They're totally devoid of context. They shout that something is off, but they can't whisper the whole story. And that is where our expert analyst comes in, the peripheral smear. Now, this isn't a machine. This is a trained human eye, looking through a microscope at a super thin film of your blood. They're not just counting, they're observing. They're looking at the quality, the shape, the very character of the cells themselves. And right here, you can see just how powerful that human eye is. An expert can spot things the machine is completely blind to. Abnormal blast cells, the specific shape or morphology of cells, fragmented bits, or even things like cell clumping that can totally fool the automated counter. We're graduating from just numbers to actual visual evidence. Okay, so let's put this into practice and solve our first mystery. We're going to call this one the teardrop clue. We've got our initial numbers, but we absolutely need our eyewitness to crack this case wide open. The CBC report comes in. Low hemoglobin, low platelets. Okay, something is clearly wrong. But the peripheral smear, it delivers the smoking gun. Teardrop cells. These are literally red blood cells that have been stretched into a distinctive teardrop shape. Along with those, we see other immature cells, a finding we call a left shift. This specific visual clue is everything. So the big question is, why are the cells shaped like teardrops? Well, it happens when something like tumor cells from metastatic breast or prostate cancer infiltrates the bone marrow. The marrow gets super crowded, it displaces the normal blood-making factory, and it literally squeezes immature red blood cells out into the bloodstream, deforming them into that teardrop shape on their way out. A teardrop cell is a massive red flag that the marrow is under serious stress. All right, let's move on to our next case and see how this builds. We'll call this one the case of the missing cells. Here, a patient comes in with something called pancytopenia, which is a fancy way of saying there's a huge drop in all the major blood cell types. Red cells, white cells, platelets, they're all tanking. So the CBC confirms it. The numbers are low across the board. But again, it's the peripheral smear that delivers the game-changing clue. The specialist sees blasts. These are very immature, totally abnormal white blood cells that have absolutely no business being in the circulating blood. In some specific cases, they might even spot these little things called Auer rods inside the blasts, which points directly toward acute myeloid leukemia. And this leads us to a fundamental, non-negotiable rule in oncology. If a patient has low counts of all their blood cells, but the smear shows the presence of blasts, you treat it as acute leukemia until you can absolutely prove it's not. This is a true hematological emergency. It signals that the bone marrow has basically been taken over by these useless, non-functional blast cells. For our last case, we've got the exact opposite problem, an overcrowded scene. The white blood cell count is through the roof, just astronomically high. So the question becomes, is this the body launching a massive all-out war against a severe infection? Or is it something else, like leukemia? The CBC alone? It can't tell the difference, it's stumped. But the peripheral smear can. In a bad infection, the smear shows really stressed out white cells, but crucially, no blasts. In chronic myeloid leukemia, or CML, the smear shows the entire family reunion of developing white cells, something called a myelocyte bulge, and, you guessed it, a few blasts. The pattern is completely different. And that pattern is what leads to the right diagnosis. Now, for a really fascinating twist in this whole detective story, sometimes the evidence from that initial report, it isn't just incomplete, it's flat out wrong. That automated CBC machine, it can be fooled. Just look at these examples. Platelets can sometimes get sticky and clump together. The machine sees this big blob and thinks, that's just one giant platelet, and it reports a dangerously low count, when in reality, the count is totally normal. Or immature red blood cells that still have a nucleus can be misread by the machine as white blood cells, which makes that count look way higher than it is. This is why you never ever treat the numbers without seeing the smear first. So this all brings us to the oncologist's investigative algorithm, their playbook. It's a really logical step-by-step process. Step 1, you get the CBC back and confirm there's an abnormality. Step 2, you immediately look at the smear for that all-important visual evidence. Step 3, you have to correlate that evidence with how the patient is actually feeling and what's going on with them. And only then, step 4, do you decide on the next big test, like a bone marrow biopsy. You know, over time, specialists learn to recognize these key patterns that just scream red flag. If all the cell counts are low, you got to think acute leukemia or marrow infiltration. Anemia plus those teardrop cells, that points straight to things like myelofibrosis or metastasis. A really high number of a specific white cell like basophils, that makes you immediately consider CML. It's all about recognizing the patterns. So what are the biggest takeaways from all this? First, always remember, the CBC gives you the quantity, but it's the smear that gives you the quality. Second, oncology is so much about pattern recognition, seeing those clues like teardrop cells that tell you the marrow is under stress, and of course, never ever forgetting that seeing blasts on a spear is always a medical emergency. And this brings us right to the final crucial idea that perfectly sums this all up. The CBC tells you that something is wrong. The peripheral smear, our expert eyewitness, tells you what is wrong. And if you need to go further, a bone marrow biopsy will finally tell you why it is wrong. Behind every abnormal blood test, there's a whole story just waiting to be told. Thanks for tuning in.